Just very excited to talk with you guys about the best specialty in the world, physical medicine rehabilitation. All right, let's start with, let's see, some PM&R history. So Dr. Frank Krusen, so he's in the upper right of this PowerPoint slide there. So he's kind of considered the founder of PM&R. He began researching the uses of physical medicine in the 1920s. He developed the field's first residency training program at Mayo Clinic in 1936. He wrote the first widely used textbook of physical medicine back in 1941. It was called The Employment of Physical Agents for Diagnosis and Therapy. Around the early 1940s, so there was a lot of injured soldiers from World War II returning. So there was a tremendous need for rehabilitation medicine, which used a lot of the physical medicine approaches. So by the mid 1940s, organized medicine had really began to accept PM&R as a medical specialty. So PM&R has been a member board of the American Board of Specialties since 1947. As of 2020, there have been 13,706 physicians board certified in PM&R. While the field has actually changed quite a bit since the 1940s, the goal of PM&R remains the same, and that is to restore function and improve quality of life. All right, on to one of the most frequently asked questions: is it physiatry or physiatry? I don't know if you've heard the second one before, but you'll hear it. Both are acceptable. Okay, I believe the very first pronunciation did put the emphasis on the third syllable, so physiatry or physiatrist, but both are correct. Both are acceptable. Or maybe the better term is whatever your attending's using. So what is a physiatrist? A physiatrist is a physician specializing in physical medicine rehabilitation. A physiatrist has training in treating disorders or disability of the muscles, tendons, bones, ligaments, joints, brain, spinal cord, and peripheral nerves. What makes physiatrists unique? So physiatrists focus treatment on function. Let's take a spinal cord injury, for example. So the physiatrist will, of course, address the medical complications from the spinal cord injury, but they will also address the mobility issues. They'll also address the issues with activities of daily living. They'll even address, maybe get them back to the sport that they love or some of the other recreational things that they love. The physiatric history will assess prior level of function as well as the current level of function. We'll even ask how many steps are going into your house. So I've actually heard attendings from different specialties say that they will look for the PM&R note to get the most thorough H&P. So we really have a unique approach to things, and the focus is on function. So you'll hear that several times. Physiatrists treat the whole person, not just the problem area. So this relates to the first point as well, but let's maybe use a different example. So somebody with chronic low back pain. Yes, we would assess the low back pain area, but what about sleep? What about aerobic activity? What about workplace ergonomics? What about stressors? What about barriers to going to physical therapy? So those are all things that we know are going to contribute to low back pain. And those are the things and part of our training that you'll focus in on, not just on the problem area, but treating the whole person. Physiatrists treat patients of all ages. So that's one of the neat things. I actually have had the honor to treat entire families. So the grandparents, the parents, the kids. And so I have one family in particular always scheduled everything all at the same time too. So it was like 3 in a row of the same family. So physiatrists will also have a broad medical expertise. So because a lot of the diagnoses that we see, they can impact multiple body systems. So you have to have a broad medical expertise. Physiatrists will diagnose and treat pain. So pain impacts function. So that's common thing that physiatrists will do. Physiatrists will lead a team of medical professionals. So in acute inpatient rehabilitation, so this might be a group of physical therapy, occupational therapy, speech therapy, recreational therapy, rehab nursing, social work, case manager, psychology, dietitian, maybe even a chaplain. So physiatrists are good at leading teams and also running team meetings. Physiatrists will work with other physicians frequently, especially neurology, orthopedic surgery, but really because, again, we deal with a lot of diagnoses that can impact multiple body systems. We interact with many different fields, many different specialties. Physiatrists treat a wide variety of conditions. So this is just a few, but I just wanted to give you an idea of the breadth of things that physiatrists will see. So amputation, upper and lower extremity, arthritis, back, neck pain, brain injury, concussion, chronic pain, congenital disorders, work injuries, muscle and nerve disorders, spinal cord injuries, sports-related injuries, stroke, wounds, many more. Physiatrists can perform a wide variety of procedures. So electrodiagnostic testing, so EMG, nerve conduction studies, ultrasound-guided injections, and also diagnostic ultrasound, fluoroscopic injections, nerve stimulators, ablation procedures, prolotherapy, spasticity management, so that's the phenol or botulinum toxin injections, nerve and muscle biopsies, acupuncture. Those are just some of the common ones you'll see. Now, some of these are residency requirements, so EMG, joint injections, diagnostic ultrasound, botulinum toxin injections. Those are ones that every residency will have to do. Some of these are maybe more fellowship level, so like the nerve stimulators or the ablation procedures. Okay, so what is the path to becoming a physiatrist? So after completing medical school, you'll match into a PM&R residency. I believe there's about 99 accredited programs at this time. The PM&R residency can be a categorical or a 4-year program. It might be an advanced program, so 3-year program after a year of a preliminary intern year. We even have some combined programs, so combined pediatrics and PM&R programs. Those are 5-year programs. I believe there's 3 of those in the country. After residency, you'll complete part 1 of your board certification exam, and that's a written exam. After that, you'll either practice or go into fellowship. And then your part 2 board exam would be about a year after you take the written exam, and that's an oral board exam. There are 7 subspecialty certifications offered by AB PM&R, American Board of PM&R. For DOs, you can also be certified through the AOB PM&R. I believe they have 3 subspecialty certifications. That's sports, pain, and hospice and palliative medicine. Currently, there are 7 ABPM or ACGME subspecialty certifications. There are a lot of other non-ABPM&R subspecialty certifications and other fellowship options as well, which we'll talk about in a little bit. But let's go very briefly, because I know you guys will be getting a little bit more in-depth presentations on a lot of these subspecialties. So I just want to briefly introduce them and describe them here. So brain injury medicine. So this is the subspecialty focused on prevention, diagnosis, treatment, and management of individuals with brain injury. So this could be stroke, this could be neoplasms, anoxic brain injury. Hospice and palliative medicine. So actually, I believe as of this year, this is actually will be through American Board of Internal Medicine, I think. But AB PM&R diplomats mates are still eligible to pursue that certification, but it's no longer through AB PM&R. But palliative medicine focuses on enhancing the lives of individuals who are suffering due to serious illness, and then hospice focuses on relieving symptoms and supporting patients at end of life. Neuromuscular medicine. So this is for both physiatrists and neurologists. We'll go into neuromuscular medicine fellowship, and this is focused on neuromuscular diseases such as ALS, peripheral neuropathies, muscular dystrophies, myopathies, myasthenia gravis, things like that. Pain medicine. So this is the subspecialty focused on the entire range of painful disorders. This could be post-operative pain, this could be cancer pain, neuropathic pain, headaches, pretty much anything related with pain. Pediatric rehabilitation medicine. So this is focused on the prevention, diagnosis, treatment, and management of congenital or childhood onset impairments. So CP, cerebral palsy, spina bifida, neurodevelopmental disorders, and then brain or spinal cord injuries in the pediatric population. Spinal cord injuries, so deals with individuals with spinal cord injuries, both traumatic and non-traumatic. Multiple sclerosis, transverse myelitis, cancer, spina bifida, certainly traumatic spinal cord injury. Last but not least, sports medicine. So this deals with sports-related activities or injuries, as well as physical fitness and maintaining a healthy lifestyle. So if you're anything like me, like hearing all of those options, it's just like, it makes you feel like a kid in a candy store. I just want you to keep in mind that you do not need to be subspecialty boarded in all of these things or any of these things to practice in these areas. There are many general physiatrists that practice in a lot of these areas, but just want to highlight how broad and of options there are in PM&R, both through certification, but even just in clinical areas. So going along with that, here are some other subspecialty or fellowship options that a lot of physiatrists will go into. So there's several cancer rehabilitation fellowships. So with after your PM&R residency, a lot of people will focus on cancer rehabilitation, electrodiagnostic medicine, so EMG, nerve conduction studies, and a lot of physiatrists will get board certification through the American Board of Electrodiagnostic Medicine. A lot of physiatrists will pursue interventional spine or musculoskeletal medicine fellowships. A lot of these are through NASS, or the North American Spine Society. So those are also very popular. There are also multiple sclerosis fellowships, neurorehabilitation, occupational environmental medicine. There are fellowships that just focus on spasticity management. There are stroke fellowships and even a wound medicine fellowship. So lots and lots of subspecialty options for the physiatrist if they choose. Now, what are the different clinical practice setups and settings that we see physiatrists in? And really, sky's the limit. I have heard so many different practice types: inpatient, outpatient, both, private practice, academic, all of those clinical areas that I mentioned, all of those conditions treated that I mentioned. Some will focus on just one of those clinical areas. Sometimes they'll just focus on amputation. Sometimes they just focus on stroke. Some will, some physiatrists, I would say more often, the physiatrist will have more than one clinical area. So they'll practice in multiple areas of PM&R. So I wanted to use my practice, I guess, as an example. So I have in academics, I have an outpatient practice. My clinical focus is on evaluation, non-operative management of pretty much all musculoskeletal injuries. So for me, that includes sports medicine. So team physician for high school and college. I provide sideline and vet coverage, cover training room. I have special interest in adaptive sports, so I had some involvement with that at a national level. That also spine medicine. So I perform interventional spine procedures under fluoro. For me, that also includes electrodiagnostic medicine. So I'll do EMGs, I'll do neuromuscular ultrasound, I'll perform nerve injections, nerve hydrodissections, things like that. Regenerative medicine. So I'll do platelet-rich plasma injections or PRP injections, do a lot of regenerative medicine consults, things like that. And then even performing arts medicine. So I'll treat dancers and other performing artists as well. So my primary procedures, again, are guided injections, diagnostic ultrasound, both neuromuscular and musculoskeletal, and then as well as EMG. And again, there's a lot of different opportunities, a lot of different practice settings. You know, I love academics. I love teaching and doing research, and so there's a lot of opportunity for all of those areas in PM&R. Okay, so maybe I've spiked your interest. What now? Okay, so like we talked about, there are a lot of different types of practice settings. So you want to shadow or rotate with different physiatrists so that you get an idea of the breadth of the field in a lot of different areas. So make sure you understand the field and make sure that you can determine that it's a good fit for you. There are a lot of resources that are available. I would highlight the AAP, Association of Academic Physiatrists, and the AAPM&R, American Academy of PM&R. They have really great medical student resources that are very comprehensive and give you additional insight and guidance in terms of how to get into PM&R. Find a mentor. Sometimes that can be difficult if your school that you're at doesn't have a PM&R department, or sometimes doesn't even have a physiatrist. But again, I would point you back to point number 2 and really look at the medical student resources. Sorry, there is an ambulance that just drove by, if you can hear that. Explore the medical student resources from the different PM&R organizations. And a lot of times they have kind of mentorship programs to kind of get you set up, things like that. There are physiatrists a lot of times in the community that are very interested in having medical students with them, either through formal rotation or just for shadowing. And if possible, get involved with the interest group. If there's not an interest group in your school, start one. There's a lot of resources in those PM&R organization websites that we talked about that talk about that as well. So what are residency programs looking for? So you've decided you want to do PM&R, and now you're thinking, okay, what are the programs looking for? So this is other than, obviously, any specialty can say good board scores, good, course clerkship grades, things like that. But what are the other things? So understanding of the specialty, I think, is very important. So understanding PM&R, so that you show that by showing your experience within the specialty. So you have to have a rotation in PM&R. Maybe that involves involvement with PM&R organizations or PM&R related groups in the community. Maybe PM&R conferences, but a PM&R rotation, at least one, preferably more, for the reasons we talked about earlier, I think are very important. And a lot of that would tie into your personal statement. So kind of describing an understanding of the field and how you came to know that you want to become a physiatrist. Physiatrists value strong interpersonal skills, working well in a team for those reasons we kind of talked about in the beginning. So demonstrating different ways that you can demonstrate strong interpersonal skills, working well in a team, is kind of by different organizations that you're involved with, volunteering, leadership experience, things like that. Performance during your PM&R rotation is very important. A letter of recommendation from at least one, if not more, physiatrists. Usually 2 or 3, no more than 3, but 2 is probably the most common, is from what I see. And then also research. I would also add too, even though an away rotation is not mandatory by any means, but it certainly is something to consider doing an away rotation. I'm just going to check the chat. I didn't know if there was, before I move on here. Oh, I have. So I think
we did have one question from Kate.
Okay. Oh, performing arts medicine. So a lot of that. So I think of performing arts medicine. That's a good question. As essentially like an offshoot of sports medicine. I mean, they're returning to play. So they have very unique injury patterns. So for dancers, a lot of times it's lower extremity. For musicians, a lot of times it's upper extremity injuries. A lot of times they're overuse injuries, things like that. So for me, a lot of times sometimes you can even have, I don't want to call them training rooms, but sometimes you'll even go to practices, rehearsals, because a lot of times they'll have injuries and it'll function almost like a training room. But it's a specialized area of, I guess, musculoskeletal medicine. Some would consider it offshoot of sports medicine. And so there's a lot of unique injury patterns with dancers and performing artists. And so did I answer your question? Are there anything more additional? So in terms of specific, I guess, training for that, there's not necessarily a performing arts medicine fellowship or things like that. A lot of sports medicine fellowships will have exposure to performing arts medicine though. So that tends to be the most common place where you'll have maybe more formal training, and then residency programs that have those performing arts medicine programs as well. So at this point, I just want to open it up for questions, either in the Zoom or on chat. Let me just kind of pull that up.
Yeah, if anyone has any questions, feel free to unmute yourself, or you can send Dr. Colorado or me a message, whatever y'all prefer.
Hey there, my name's Carter. I'm from TCOM here in Texas, in Fort Worth. But my question would be, I've seen some like outpatient PM&R and like some more musculoskeletal, like neuromuscular sort of things, but I guess it's harder to shadow inpatiently. So what, could you talk a little bit about what that would look like as an inpatient doc, and like how busy they can be, or what kind of like acute patients they see, or just what that life looks like?
Yeah, so that can look a little bit different depending on the setup. So there are some inpatient rehab places that break it down into brain injury, break it down into spinal cord, break it down into stroke. So they may just see that area. And then there are other inpatient rehab units that they just see all comers. So the inpatient experience at one place that maybe sees all comers versus one where all of the patients that you're seeing is spinal cord injury could be different. So if you look at some of the away rotation offerings at different places, sometimes it's just spinal cord, sometimes it's just brain injury. If you're looking to kind of get introduced to the field, I would potentially favor the one that you get a little bit of exposure to each. I would say most of the, at least neuro rehab physiatrists that I know will, in addition to that inpatient portion of their practice, they'll also have outpatient practices usually in the afternoon. So they'll kind of round with the team in the morning, and then they'll see patients in the clinic in the afternoon.
Okay. And so do they typically like handle like the internal medicine? Like, are they can be either consult or they can be the primary? Is that correct?
Yeah, so again, that may be based on the system. So there are some physiatrists that will handle everything. They'll handle all the medical issues that come up. And then there are some setups where internal medicine is managing a lot of the medical conditions, and the physiatrist is really focusing on the rehab portion of the management. So you will see a lot of different setups, and some physiatrists want to maintain their diabetes management and blood pressure all of those types of things, and some really just want to focus in on the rehab management. And so a lot of times the hospital service or the internal medicine service will follow for a lot of the other medical issues. Any follow-up questions to that? Did that answer your question?
That was great. Yeah, I appreciate that.
We have a question from Akash. Would you recommend doing the PM&R away rotation during the 3rd or 4th year?
So I would, in an ideal situation, in some cases, you just have to take what you can get. So sometimes you don't have a choice. But if you can, especially if it's an away rotation at a program that you're very, very, very interested in, I would not make it your very first rotation. So if you had a rotation at your home institution, or there was another rotation that so an away rotation is really your chance to shine at that rotation. Now, if it's the only PM&R rotation that seems to work for your schedule, you really have to take what you can get sometimes, because unfortunately there are some cases where the rotations get so full. So, but in an ideal setting, your away rotation, you really want to maybe make it at least your second rotation, and it gives you an opportunity to really shine at that program.
And then Jonathan said, your practice seems vast. Did you do a fellowship after residency?
Yes, so I did a sports medicine and then also an interventional spine fellowship. And so my fellowship had a lot of EMG as well. So that's so I sat for the EMG boards after that as well. But a lot of the spine procedures are going to need a fellowship.
And then Taylor had his hand raised.
Yeah, hi there. I'm Taylor from TCOM. My question is in regards to fellowship training. Do you see most PM&R docs doing a fellowship, or do you see a lot that go and just practice right after finishing their 4-year residency?
I think it's a good mix. I do think there's maybe I don't know the exact numbers, but because there are more and more fellowships being created, I do maybe see a little bit trend more towards doing a fellowship, but for the most part, there's a pretty good mix. Now, if you're interested in more interventional, pain, sports, MSK, I would say it's probably more common to do a fellowship. But I also know of a lot of general physiatrists that do quite a bit of musculoskeletal, and they never did a fellowship. So I think ultimately it might depend on your the end practice, whether or not you need it. So, but if you're maybe more in an city or urban area where there's a little bit more saturation, it might be a little bit more important to have fellowship training in those cases.
Awesome, thank you.
And Jonathan had a follow-up. Was that a joint program you did, or one of each for the fellowship?
No, it was a combined. So there, so it was an ACGME sports medicine, but it had a significant amount of interventional spine during that year. So it was not an ACGME pain fellowship. So there's a lot of that's probably a whole other talk. But there's pain fellowships, ACGME pain. There's ACGME sports. And then there are non-ACGME accredited interventional spine and musculoskeletal fellowships. And there's a big kind of continuum. There's pros and cons to each. Ultimately, it really depends on your interests and career goals.
And, Mr. Davis got a question.
Yeah, I was hoping, Dr. Colorado, if you could speak more to the like, do your residents get involved with your sports medicine practice, like via sideline coverage, or even with like the adaptive sports? Could you perhaps list some examples of some of the adaptive sports interventions that you've been able to provide?
Sure. So full disclosure, I've been at my new position here for a month. So my answer is gonna be a combination of my prior practice, how the residents and fellows were involved there, and also from what is going to be set up here. So it's a little bit of a mixed response, but yes. So I usually, I'll cover high school football. So residents will usually join me on the sidelines for coverage. A lot of times there's going to be events, whether it's marathons, things like that. So mass event coverage. So they'll join with that. When I ran a sports medicine fellowship, so we would have regular training room coverage once a week. So we'd go to the university and see athletes there at a set time once a week. From a other sports medicine standpoint, so we tried to have a variety of coverage options, so different levels. So high school, college, even sometimes some professional level. From an adaptive sports standpoint, so I help out with the National Veterans Wheelchair Games. So that's kind of a annual type thing. So it's a 1 week multi-sport event. So there's I think 18 different events. So we'll provide coverage both at the event sites, but since the athletes are there kind of all week, so we'll set up kind of hotel clinics. And so if there's any issues that arise, and we've had residents and fellows come to that as well. From a adaptive sports standpoint, we're blessed here where I'm at right now, where we have a partnership in the community with Lakeshore Foundation, and so there's a lot of adaptive sports opportunities there. So many different adaptive sports teams that if any of their athletes have any injuries, or if they have tournaments or games that need coverage, those are also opportunities as well.
It was really fascinating. Thank you.
Anybody else have any questions?
I have one question. I've been interested to see what your take on is. I have some younger girls who say, isn't PM&R just a boys club and all of them are just all about sports and there's nothing else in here? So I obviously don't think that going into PM&R, but I wanted your take on it.
I will say that some of my most significant mentors in sports medicine have been female. So I don't think that's the case at all. I think in almost every area or subspecialty in PM&R, you see a great mix of male and female leaders, which is great.
Thank you so much.
Anybody else?
I have a question.
Yeah.
Hi, I just wanted to ask if you're doing, let's say, a third or a fourth year away rotation in PM&R, are there certain skill sets that are expected from you? Like, for example, how to do certain types of injections or EMG studies and things of that sort?
No, don't worry at all about procedures, okay? Really, we're looking for, so most of the time you're going to be in an inpatient setting, but there a lot of times the rotations are set up either all inpatient or all outpatient. So there might be a couple different approaches, because an outpatient rotation is going to be a little bit different than inpatient. However, really they're looking for somebody that's very interested in learning more about the field. A lot of us know that it's not an area that people get exposure to very much. So the last thing you worry about is, am I going to be good at these procedures? Because really we're looking for somebody that wants to learn as much as they can about the field, shows interest. A lot of just the basic H&P skills that you already know. I mean, if you do those really well, very good bedside manner, those types of things are really all you need to know going in. But at the same time, a good base in neurology, a good base in orthopedics doesn't hurt.
Okay, thank you so much.
Yeah. So base it off of the rotation. So if it's going to be an outpatient rotation, I would guess there's going to be a fair amount of spine. So that would be the area you might want to focus in on going in. Look up the physiatrist. So what is their specialty area? That gives you a clue. From an inpatient side, the neuro exam would probably be the most important.
Gotcha. Thank you so much for the tips. They're really helpful.
Anybody else?
I have a quick question, Dr. Colorado.
Yeah.
Thanks so much for your time again. So I am very interested in pediatric PM&R. But my question is, if I were to do peds PM&R, would I be limited to doing peds only? Because I really want to be involved in sports, not only at the high school level, but I'd love to do college too. And maybe even beyond that. But so do you know of anybody who is a pediatric physiatrist, but who also does sports for, collegiate, professional, or even Olympic, or who is involved at that level as well?
Not maybe to that level, but I do know of some that do that still do some sports, usually more at the high school or the youth sports level. Part of it is, as a pediatric physiatrist, you are in huge demand. So it becomes one of those things where, okay, you've got this sports, the sports area where there's a lot of people who do that. And then you've got the pediatric physiatry area where everyone is in need of you, so it becomes harder and harder. And now if you really made sure, and if it was a priority for you to, really have that sports area, it can certainly be done, but it's one of those things where I think because of the huge need in pediatric PM&R and the lack of specialists in that area, it becomes harder to do some of the other stuff, but it certainly could be done.
So it sounds like it would be more of a time issue rather than training.
I think so. Yeah.
Okay. Awesome. Thank you.
Yep.
Some great questions. Keep them coming if you have any.
I can speak real fast, Dr. Colorado, too.
Yeah.
So most of us who are looking to go into PM&R wouldn't graduate residency until 4-7 years from now. Is there a certain path or trajectory you think that PM&R is heading that's different than it is right now, 7 years or 10 years from now?
I think everything goes in waves. I think right now the wave tends to be a little bit more outpatient, musculoskeletal, but then again, once there's a big need again for more inpatient, then it's gonna swing back. So I think there's need everywhere, and I think physiatrists especially are trained to be able to have value in a lot of different areas and a lot of different systems.
Thank you.
From a musculoskeletal kind of sports standpoint, I think the regenerative medicine is a very kind of hot button topic that there's a lot of interest in, and certainly pain, sports, MSK, those are rapidly evolving fields as well. But really, you could say that about any area. So even in spinal cord injury, there's so many advances that are potentially coming down the pipeline, and so many advances in stroke and brain injury that it's really an exciting area for all the subspecialties.
All right. Thank you so much for your time, Dr. Colorado. I learned so much, and I thought this was an incredible eye-opening experience of the endless possibilities that are really available to all of us. And thank you everyone else for coming out. I know everyone's busy, so I really appreciate y'all coming. Our next session is going to be November 9th at 6 p.m. Central Time with Dr. Elwert from Kentucky, talking about stroke and neurorehabilitation. So they'll probably give some good insight into some of those inpatient stuff that we hinted on tonight. So if anyone else doesn't have any other questions, thank y'all so much for coming. We really appreciate y'all. Have a great week.
And
Thank you so much.
I'll hang out a little bit. I'll hang out for a little bit if anyone wants to hang out and have a few more questions. But thank you guys for your interest in PM&R.
Yeah, thank you.
Dr. Colorado, I had a question real quick,
Yeah.
kind of a two-part. First, do you see a lot of physiatrists doing like private practice, either through like adaptive, like having a clinic and then having like an adaptive exercise, like gym set up, where they bring in people who are like either doing therapy or are doing, like specific exercises for whatever treatment they need? And then what do you think is the best pathway to take if you want to be involved in adaptive sports as a physiatrist?
I'm going to answer your questions in reverse. So from an adaptive sports standpoint, there's a lot of different pathways. So some will go through the sports medicine path, and then they kind of do adaptive sports as kind of the offshoot. But the other way is the vast majority of athletes, wheelchair athletes, are spinal cord injuries. So a lot of them go down the kind of the spinal cord injury pathway, and then that's how they came into the area. But either way, I mean, even some general physiatrists will get into adaptive sports. Really, it's starting at kind of your community level. There are a lot of providers who might be willing to cover, or willing or able to cover, able-bodied sports. But when you start to look at adaptive sports, either, docs may not just feel as comfortable. And so that's really a lot of people who kind of got into adaptive sports kind of fell into it, where they kind of filled a need in the community, and then they slowly became more and more involved. So that's usually the best way to start, is to, there's a lot of adaptive sports organizations within the community. And you'll be surprised, even in bigger cities, a lot of them will have tournaments. They have teams that have never had medical coverage. So I know a lot of people have just approached the organization or the team and said, hey, can I volunteer, and can I be your team doc, or can I cover these games? And then that's how the relationship starts, and things like that. So the first part of my question was kind of more how people sometimes formally get into it, but a lot of times the common way is just be getting involved at the community level with different organizations. Your first part was in terms of private practice, and were you talking specifically about like adaptive athletes, or are you just talking about like rehabilitation in an outpatient setting?
Sort of like a mix of both. Like where I'm at right now in Northwest Arkansas, we have like a kind of a makeshift adaptive exercise program going for spinal cord injury patients and Parkinson's patients. And I was just wondering if, like having a clinic set up where you get to, train with those types of individuals as a physiatrist in like a private practice setting is like a common thing, or if that's just not really seen.
I think that's less common. I think it's mostly associated with the hospital or the health system in terms of those. Now, the outpatient kind of therapy that you're going to be more likely to see in a private practice setting is musculoskeletal. So sports, musculoskeletal pain practices, a lot of them will have their own physical therapy groups a lot of times. in those more of the partner groups, you know, you're less and less you're seeing those solo practitioners, unfortunately, but that's what you're describing is probably less common, but I'm sure it exists somewhere.
Awesome. Thank you for the answer.
Yeah.
Yeah, that's an interesting question, Baylor. I thought about the same thing about sort of combining like gym interests and musculoskeletal practice.
Yeah.
But Mike, oh, sorry. Go ahead.
No.
Dr. Costa.
I wanted to follow up one more thing because I know a lot of people who have like a sports and spine practice, like clinic during the day, and they're still covering the inpatient floor and doing consults like in the morning before they're, you know, so you don't have to choose inpatient or outpatient. So you don't have to, that was one of the things I wanted to emphasize. You can really, even if they seem like two completely different parts of this PM&R spectrum, for lack of a better term, you can still do it. Sorry, didn't mean to interrupt. Go ahead.
Yeah, no, that's cool to see it. How you can have your own blend, whatever you want. But my question would be about your academic triple threat schedule. Like, how do you split up your time between research and education and practice? And like, maybe what are some pros and cons of doing all three?
So for the past 8 years, I was in an academic practice, but I was like pretty much 95% clinical. So I was doing a lot of my academic interests, like research and teaching. A lot of that was not necessarily built into my schedule. I'm in a situation now where I'm more like half and half. So I have a lot more built-in time for teaching and research. It really depends on maybe your practice setup, because I know there are some physiatrists who are heavily involved in research and they, you know, get grants and things like that. They do 25% clinic and then 75% kind of research. So it really it is hard to do all of that if you're like 100% clinical, because that ends up being a lot of evenings, a lot of weekends, but a lot of setups have it where you can kind of mix.
I see. That's interesting. And for your research aspect, like how does that work? Do you just like come up with an idea and then like you have research assistants that you sort of guide along, or how much like hands-on work, or I'm not sure what that looks like, I guess.
So for me, that's a great question, because there's a lot of different ways. There's lots of levels of research. So a lot of mine is clinical research, and I partner with some of the surgeons and things like that. So for a lot of my projects, I would say they're smaller projects, but my bigger ones are in conjunction with some of the orthopedic surgeons that I've worked with, things like that. So ideally, if it's a research project that's tied to your clinical interests, right? So your clinical expertise is now feeding into your research expertise, and now the same patients that I'm trying to recruit for this research are the same patients that I see on a daily basis. Now you've just created this synergy, and it makes it easier to do research. And now you're able to teach, you're able to lecture about these things, because now you're seeing all these patients, you're doing research on these same patients, and now you're educating people about that management. So try to pick a research focus that's tied into your clinical focuses was an advice that was given to me from a mentor, and it really makes things easier.
Yeah,
I shouldn't say easy.
Yeah, thank you. I appreciate it.
Awesome.
Hi.
Oh, hey.